Melasma, formerly known as chloasma, is an acquired pigmentary condition occurring most commonly on the face. This disorder, which is more prevalent in females and darker skin types, is predominantly attributed to ultraviolet UV exposure and hormonal influences. Melasma is generally a clinical diagnosis consisting of symmetric, reticulated hypermelanosis in three predominant facial patterns: centrofacial, malar, and mandibular. Morphologically, melasma presents as symmetric reticulated hyperpigmented patches with irregular borders on the centrofacial region, malar cheeks, mandible, and rarely upper chest and extremities. While melasma is known to more commonly affect darker skin types, it can occur in all skin types. On dermoscopic examination, it is possible to see pronounced hyperpigmentation in the pseudo-reedy ridges of the skin. Using a Woods lamp, the hyperpigmentation can be accentuated when the pigment is epidermal. However, this accentuation may be seen with dermal or mixed melasma. Reflectance confocal microscopy (RCM) has also been used to evaluate melasma on a cellular level. In the epidermis, it has shown an increase in hyperrefractile, cobblestoning cells which corresponded to hyperpigmented basal keratinocytes on histology. In some patients, epidermal dendritic cells can also be found corresponding to activated melanocytes. In the dermis, RCM may show plump bright cells corresponding to melanophages as well as solar elastosis in blood. RCM is a non-invasive technique that detects pigmentary changes in melasma at a cellular level resolution. The differential diagnosis for melasma includes lichen planus pigmentosus, discoid lupus erythematosus, phototoxic dermatitis, erythema dyschromium persistens, phytophotoderitis, pigmented contact dermatitis, drug-induced pigmentation, poikiloderma of civet, erythromelanosis follicularis faciae, ochronosis, horis nevus, argyria, nevus of Oda, lentogens, ephelides, macular amyloidosis, and post-inflammatory hyperpigmentation. Treatments for melasma include topical, oral, procedural, and combination treatments. These are aimed at various aspects of the pathogenesis of melasma, including photodamage, inflammation, vascularity, and pigmentation. Topical treatments, including photoprotection, are typically the first-line therapies for melasma. The most common therapeutic agents used are those that inhibit the production of melanin through melanogenesis and melanocyte proliferation. Concomitant use of various topical therapies with different mechanisms of action are preferred to monotherapy and visible light avoidance are critical to prevent flares and exacerbation of melasma. In repeated randomized controlled studies with 40 to 60 subjects, a comparison of broad-spectrum UVA and UVB filters combined with visible light blockers such as iron oxide versus broad-spectrum UV filters alone showed reduced melasma relapses in the former group. Hydroquinone HQ has historically been the most studied topical agent in the treatment of melasma. This compound works by inhibiting tyrosinase, which prevents the conversion of DOPA to melanin. Others have postulated that it can also directly lead to melanocyte destruction and melanosome degradation. In several studies, the use of HQ 4% has led to a statistically significant improvement of melasma dyspigmentation. Although very effective and dosed at different strengths, it can cause an irritant dermatitis in some individuals, and chronic use can lead to exogenous corticosteroids can prevent pigmentation by non-selective suppression of melanogenesis while also serving as an anti-inflammatory agent. Corticosteroids alone are unlikely to be superior to depigmenting agents when used as monotherapy. Although they have an independent ability to suppress melanogenesis, the current literature shows that corticosteroids have not been demonstrated to have long-term benefits in treating melasma. Moreover, long-term steroid use may lead to telangiectasias, acne, epidermal atrophy, striae, and hypopigmentation. Topical retinoids have also been effective in treating melasma, with a postulated mechanism of promoting keratinocyte turnover. A small but sentinel study in 1993 showed that tretinoin 0.1% cream could significantly decrease objective colorimetry measurements of melasma pigmentation. Another study has confirmed the beneficial use of retinoids 0.1% cream for the treatment of melasma in Black patients. Natural topical compounds in recent years. Naturally occurring compounds have been investigated for their therapeutic activity against pigmentation. Niacinamide, which inhibits melanosome transfer to keratinocytes, has been shown to decrease pigmentation in a small study with 27 subjects. Both ascorbic acid and kojic acid can inhibit tyrosinase activity and have been shown in small studies to lead to decreased pigmentation. Ascorbic acid has a theorized benefit of decreasing reactive oxygen species, which decreases inflammation in melasma lesions. However, both were shown to be inferior to HQ in improving NASI scores when used as monotherapies. Another natural compound, azelaic acid, AA, was noted in an open-label study to be effective in improving pigmentation by inhibiting tyrosinase activity. This compound, which is derived from the yeast Pyrrhosporium ovale, also has anti-inflammatory effects. Adverse effects are not common but can include burning and erythema. Thallus perennis, a flower extract that inhibits melanin synthesis, was demonstrated in combination with topical licorice and emblica, another natural antioxidant, to be similar in efficacy to HQ 2% in decreasing pigmentation and inhibiting inflammation through the arachidonic acid cascade. Other topical natural compounds used, such as lignin peroxidase, arbutin, and soy, have also been used to treat melasma in small studies with favorable results. Combination topical compounds. Recent studies have shown that combination topical therapies are superior to monotherapies in efficacy. Triple combination therapy TCT with HQ, a retinoid, and a topical steroid was the first combination topical therapy to gain United States Food and Drug Administration approval. In an investigator-blinded randomized study with 260 Asian patients, TCT with HQ 4%, tretinoin 0.05%, and fluocinolone acetonide 0.01% was superior to HQ 4% monotherapy in improving melasma. Of note, about 50% of patients on TCT reported increased erythema, skin irritation, and discomfort when compared to 14% of controls. Dual therapy with triamcinolone 0.1% and HQ 3% was also demonstrated to improve melasma among female Korean patients. Camouflage with the recurring nature of melasma and the long, challenging treatment duration, cosmetic camouflage can provide patients with another option to improve the psychosocial effects of the condition and quality of life. Cosmetic camouflage, including concealers and other pigmented cover-ups, has been shown to significantly improve the DLQI in a study of 24 patients with pigmentary disorders. Several cosmetics brands offer pigmented foundations and concealers that may even skin complexion and may also include broad-spectrum UV blockers. Oral, in addition to topical therapies, oral therapies are emerging as additional treatment options for this disorder. Tranexamic acid, TA, an antiplasmin agent, decreases the generation of arachidonic acid, which leads to a reduction in melanocyte stimulating hormone MSH and a decrease in pigmentary production. One study showed that TA may also decrease VEGF and entothyline-1, both of which may be responsible for increasing vascularity in affected lesions. While formulations of tranexamic acid have not been directly compared, recent studies generally suggest that about 90% of patients treated orally improved after 2 to 6 months, compared to about 95% of patients treated with topical 2% preparations and who improved after 3 months. Notable adverse effects of oral TA include abdominal bloating, headache, tinnitus, menstrual irregularities, and rarely deep venous thrombosis, DVT. Due to the serious risk of a DVT, screening for risk factors of thrombosis is necessary before initiating treatment. Alternative medications such as polypodium leukotomos, place, and glutathione have also been studied as adjunctive treatments with positive results. PL has been shown to decrease UV-induced photodamage and inhibit ROAS, which in turn decreases the T-cell mediated response that leads to increased inflammation and pigmentation in the skin. In a randomized controlled trial in the Philippines, oral glutathione, a naturally occurring compound, resulted in decreased melanin when compared to those taking placebo over a 4-week period. Glutathione is thought to act as an antioxidant that decreases inflammation. The recent literature on procedural melasma therapies has predominantly included case reports and case series that evaluate the use of chemical peels, microneedling, microdermabrasion, and lasers, typically in conjunction with other treatment modalities. It is important to note that many procedural studies include concomitant use of topical therapies and photoprotection. Chemical peels have been studied as an adjunctive treatment modality for melasma due to their ability to increase epidermal remodeling and to increase keratinocyte turnover. Chemical peels are frequently used in combination with other topical products. Several studies have suggested that superficial peels may be beneficial for the epidermal subtype of melasma. Amongst the various peels, glycolic acid (GIA) has been most extensively studied in the treatment of melasma. A small open-label study found that 30 to 50% got peels at 3-week intervals for 6 months in addition to a 20% twice-daily regimen resulted in superior MASI scores when compared to a 20% alone. However, a small split-phase study found no difference in decreased pigmentation when using HQ 4% with DA 20 to 30% compared to HQ alone. Another split-phase study showed no difference in a regimen with salicylic acid, SA 20 to 30% peel and HQ 4% compared to HQ monotherapy. Microneedling. Another adjunctive treatment is microneedling or mesotherapy, which creates small channels in the skin to deliver small amounts of topical drugs intradermally. The skin punctures induced by microneedling can also stimulate a beneficial wound healing response with fewer side effects compared to conventional resurfacing procedures. This technique may result in a deeper and more even placement of the medication to the epidermis and dermis. In a randomized study using multiple microinjections of TAE intradermally compared to cycles of microneedling alone followed by the application of topical TAE, the data showed possible clinical benefit with use of microneedling but no statistically significant benefit. A prospective study of patients treated with topical lightening agents, Rucinol and Sephora alpha alone compared to use of those topicals with microneedling, demonstrated a significant improvement in MASI scores when administered with microneedling. A limitation, however, is that the study was not blinded to either the patient or the investigator. Laser and light treatments. In more recent years, laser therapy has been investigated to treat melasma with varying success. Lasers can utilize thermal energy to selectively target various chromophores in the skin. Non-ablative lasers are preferred for the treatment of melasma over ablative lasers given the tendency to cause less inflammation and subsequently less post-inflammatory pigment alteration. PIPA. Non-ablative Q-switched lasers, including the Q-switched ruby laser, QSRL, and Q-switched neodymium yttrium aluminium (GUND-YAG) lasers, selectively target the chromophore melanin. When used as monotherapy, neither QSRL nor QND-YAG have been found to have long-term benefits in treating melasma. However, one small study found that using low-dose fractional QSRL significantly decreased MASI scores. More recent studies have found improvement in pigmentation with low-fluence QND-YAG, although the patients also applied sunscreen, HQ, tretinoin, or ascorbic acid after laser treatment. Intense pulse light (IPL) has also been used successfully in several smaller studies for the treatment of melasma as a monotherapy and in combination with QSRL. Fractionated IPL monotherapy used for melasma maintenance treatment resulted in improvement in MMASI scores over 14 weeks. Some authors postulate that repeated IPL treatments may promote the upward shedding of the melanosomes destroyed by QSRL. Therefore, they suggest that combined IPL and QSRL therapy may decrease the risk of post-inflammatory hyperpigmentation, PIH, and therefore may also require more treatment sessions. Other ablative lasers, such as carbon dioxide, CO2, erbium, YAG, and non-ablative fractional lasers, have also been used with varying success to treat melasma. CO2 lasers have been used in clinical trials with Q-switched alexandrite lasers, but have been repeatedly found to be associated with PIH, especially at the periphery of lesions. A recent split-phase study using low-power CO2 laser versus QND-YAG showed improved MMASI scores on the CO2 arm without a significant difference in adverse effects. YAG laser has also been shown in a small study with 20 patients to improve Pigmentation using MASI scores, but recurrence was observed at 3 to 4 months. 2 studies that utilized a fractional non-ablative 1550 nm erbium-doped fiber laser demonstrated IMPROVED pigmentation in about 60% of patients using investigator-created metrics. Neither study demonstrated long-term complications. Other energy sources such as monopolar radiofrequency (RF) have been used to treat melasma. RF causes cellular biostimulation, intracellular oxygenation, and vasodilatation. In a prospective study of 50 patients, monopolar RF was used to deliver kojic acid with improved MASI scores and decreased inflammation, but there were no controls. Using only topical therapy, thus limiting data interpretation. With increased recognition that inflammation and angiogenesis may play a role in the pathogenesis of melasma, a copper bromide anti-angiogenesis laser was evaluated in 4 Korean women who received 4 treatments over 8 weeks. Treatment was found to significantly decrease the MASI score and decrease endothelin 1 and VEGF on immunohistochemistry. Conclusions: melasma continues to be a frustrating condition to treat and one with significant psychosocial implications. Treatment efficacy can vary due to several factors including variability in clinical presentation and response to treatment amongst different genders, skin phototypes, and ethnicities. Given the multifactorial etiology of melasma, it is important to have a multi-mode therapeutic approach that addresses factors such as photoprotection, inflammation, vascularity, pigmentation, and hormonal influences. New research continues to increase our understanding of melasma and how it can be best treated. The past decade has seen the emergence of new topical, oral, procedural, and combination therapies. Greater understanding of the pathogenesis of melasma will help in the development of future treatments for this common, yet challenging condition.